Hello, my name is Tahmina Mustafa and I'm a professor of global health at Center for International Health, University of Bergen. In this lecture, I'm going to talk shortly about diagnosis of latent tuberculosis by using IGRA tests. Interferon gamma release assays, also called IGRAs, are whole blood-based tests that can aid in diagnosing Mycobacterium tuberculosis infection. IGRAs, they measure a person's immune reactivity to Mycobacterium tuberculosis. White blood cells from most persons that have been infected with Mycobacterium tuberculosis will release a cytokine called interferon gamma when they are exposed to antigens derived from Mycobacterium tuberculosis. The IGRA tests are based on the production of interferon gamma from immune cells after stimulation with Mycobacterium tuberculosis specific antigens, for example, EZ6 or CFP10. And these antigens, they are not present in most of the environmental mycobacteria and BCG, with some exception. A few of the environmental mycobacteria does produce, do give reaction with the quantiferon TB test, and these some are known are Mycobacterium kansasi, Zulgai, and Marinum. The two IGRA tests that have been approved by Food and Drug Administration USA and which are commercially available are quantiferon TB Gold in-tube test, and the other one is ELISPOT assay with the commercial name of T-SPOT.TB test. The antigens testing methods and interpretation criteria of the various versions of IGRA tests could vary. In the quantiferon TB test, blood is drawn from a patient and mixed with the antigens derived from Mycobacterium tuberculosis in the same tube where the blood is drawn. And then the blood is stimulated with these specific antigens by overnight incubation. The T cells of the infected persons, they will respond by secreting interferon gamma. Finally, the interferon gamma concentration in the plasma is determined by using a sensitive ELISA. Assessing the IGRA sensitivity in absence of a gold standard for latent TB is challenging, and studies have therefore used surrogate markers such as active TB, culture positivity, and correlation with degree of TB exposure in contact investigations. And these studies, they suggest that a sensitivity of a quantiferon TB test is almost similar to the tuberculin skin test. However, it is more specific, and sensitivity of ELISPOT TB test is slightly better than quantiferon TB test. The T-SPOT TB test is based on the same principle. The difference from the quantiferon TB test is that it enumerates the response of effector T cells that have been sensitized to Mycobacterium tuberculosis. The sensitivity is slightly better, especially in immune-compromised individuals, because this test utilizes a standard number of peripheral blood mononuclear cells to correct for patient's immune status. IGRA test has certain advantages over tuberculin skin test. For example, it requires a single patient visit to conduct the test, and the results, they can be available within 24 hours. This test does not boost responses measured by subsequent tests like tuberculin skin test. Prior BCG vaccination does not cause a false positive IGRA test result. However, IGRA tests also have some limitations. These tests cost more as compared to tuberculin skin test, and this is a factor which we need to take into consideration thinking of its implementation in low and middle income countries. Also, this test cannot distinguish latent from active TB, just like tuberculin skin test. It could be negative in people with TB disease. The sensitivity for diagnosis of active disease is shown up to 55 to 88%. Furthermore, we don't know the importance and predictive value of absolute interferon gamma response. There's limited data on the use of IGRAs to predict who will progress to TB disease in future. For example, we don't know if a stronger response correlates better with risk to disease progression or if it correlates better for diagnosis of active disease. Furthermore, there are some limitations in processing of samples. For example, blood samples must be processed within 8 to 30 hours after collection while white blood cells are still viable. Errors in collecting or transporting blood samples or in running and interpreting the assay can decrease the accuracy of the test. We also don't know how the preventive treatment affects the test. A study by Turumori showed that there has been a variable reduction in test after preventive treatment, but we don't know the real kinetics. We also don't know how the time after infection influences the test results. It seems that the test becomes weaker with remote infections, but kinetics of weaning are not known. IGRA tests represent a new paradigm with the potential to supersede the tuberculin skin test. However, the evidence base supporting their use is limited, even though it has been expanding over the last few years. A study conducted in 2009 looked at the agreement between tuberculin skin test and IGRA assay. And this study showed that among 1,161 individuals who were positive with tuberculin skin test, only 437, that is 1/3, were positive with IGRA test. And among those which were tuberculin skin test negative, there were 2,390 individuals. 115, that is 5%, were positive with IGRA test. And this slide shows the algorithm of all possible outcomes resulting from parallel IGRA and tuberculin skin testing. The studies are published in 2009 and a revised version was published in 2010. And I would request you to go through this slide. And there has been a lot of discussion on whether one should choose between IGRA and tuberculin skin test for diagnosis of latent TB, or one should use both tests. For example, IGRA should be done on those who are first tested by tuberculin skin test. But in 2015, WHO came with the following recommendations, namely that either tuberculin skin test or IGRA can be used to test for latent TB infection in high income and upper middle income countries. Also, IGRA should not replace tuberculin skin test in low income and other middle income countries.